So Erickson and Cassie, you all had the colloid crystalloid debate.
Yep.
And what I asked you to do was just give us highlights. What is the most useful information relevant to our clinical practice that you can relate to us in the next 10 minutes regarding the state-of-the-art review? Take it away.
So a lot of the review is just kind of a lot of the basic stuff that we've been hearing about for years, kind of in the periphery of head of starch, especially in humans, has been quite extensively researched and proved to cause acute kidney injury, coagulopathies. But at this point, there's still no veterinary data proving that this happens. Kind of one of the points that I thought was interesting was that they went over the effectiveness of how much you're really cutting down the fluids using colloids versus crystalloids, and they didn't think that it was really that much of a difference. It was like you used the one amount of crystalloids or for colloids you'd use 1.2, so it really wasn't that much of a difference. So you're not really gaining as much of a benefit as we'd like to think. But the other part that was good to note was that in humans, when they're using the colloids, when they have intensive care, they're staying in the hospital for extended amounts of time, so weeks to months, versus our patients, when we put head of starch, one, they're typically only in the hospital 1-2 weeks max, and then they're not on head of starch the entire time we're there. So I think from what I can tell, it sounds like we use them much more judiciously, cautiously in medicine. And then kind of taking it back to that paper we had, the fluid review we had quite a while ago, is that not only using head of starch you can use, but you could also just use actual medication, CRIs, dopamine, dopamine to help increase blood pressure versus using the colloids. And then they talk a little bit about replacement with true non-synthetic products, so human albumin, which works great in people, but they talked about some people have tried to translate that over and use human albumin in dogs, which kind of, as expected, there were massive amounts of reactions to that type 3 hyperactivities resulting in horribleness and death. So because they created an immune response because we're using something that's not theirs.
It was kind of interesting with that, kind of in that same vein of, I guess their thought was because they're immunocompromised and not producing, that it would be less, but it sounds like there may be the possibility for a rebound.
Mm-hmm.
The body's at least seen it, whether or not it could mount a response, it's still seen it.
So just a word about human serum albumin. I've actually used it. I was actually practicing a few years ago when we had the canine lyophilized albumin. That was a real boon to us, and I don't really know why it was taken off the market. There's been some word down the grapevine that there's some companies looking at substituting the canine lyophilized and making it available to us again, and I think that's going to help us a lot. Serum albumin, pardon?
How cost prohibitive was that, though? Wasn't it like $700 or $800 a bag?
It was lyophilized, so it was a powder that we reconstituted, and that made the shelf life really long. And as far as expense, when I was practicing in California, I don't really remember what it cost, but it was not cost prohibitive.
Okay, because I was thinking that when we learned about it, they talked about it, but one said it came off the market, and two said it was almost cost prohibitive. But
it may be what things cost in different areas of the country,
yeah,
and what people expect as being cost prohibitive or not. But I liked using it. I didn't have it for that long. As far as human serum albumin, my experience with it has not been really rewarding, but I think part of that's patient selection. Because using it, it was always used as a salvage therapy, like last-ditch effort to make a difference in these severely hypoalbuminemic dogs. And they, of course, were already very ill towards the end of their disease trajectory. And I'm not really sure if it was the human serum albumin or if it was just their disease that eventually caused their demise. So I've had some experience, didn't experience any serious reactions during the time that it was being administered, and my N number is probably 5 or 6. But these patients did go on to die, and I think a lot of it was just patient selection.
I
Any,
feel the
go ahead.
case. I feel as if that's the like when they're doing all these studies. I guess kind of you'd have to actually look back and see what they did with the studies because they say it's a higher morbidity mortality when you're using the head of starch, but we're using the head of starch as a second line, so
Yeah.
we're using even more critically ill that are probably going to die anyway.
Yeah, so that's a thought that could be a bit of bias. Confounding in terms of comorbidities and patient selection could create some bias in the outcome. Do you have any other more comments, Tim?
Not really. I mean, overall, I did like this paper. It was a good review on kind of everything, on the crystalloids, on the colloids, on kind of some of the pathophys that, like, we hear some things and it's not necessarily explained. So I think this, all in all, did a good job explaining. So
Yep, the benefit of a state-of-the-art review, right?
yeah, it was good.
Okay, we're going to go on to our next topic. We can reset the timer for 10 minutes. And I believe Chris and Teresa had controversies in the use of head starch and head starch solutions. And again, just a 10-minute overview, most pertinent information that you glean from the paper that you think is useful and relevant to our practice.
All right. Well, I guess just first starting off, I didn't realize kind of it talks about the rise and the fall of the head of starch solutions. I didn't realize the controversy stems out of in December of 2010. A lot of the body of research that came out as far as the benefits of using these synthetic colloids. The author of those papers had a lot of his research retracted due to papers that seemed to be unethical or deemed unethical, and some of the data perhaps fabricated. And so that's kind of what caused everything to come into question as far as how good these are in patients. But that was probably one of the most interesting parts of the paper that I read, certainly.
Yeah. I can actually remember when that happened. It was huge, and that caused them to go back and look, because all of his stuff was pro head of starch. All of his stuff was it's beneficial, it does this, it does that. And when it was brought to light, I'm not really sure how it was brought to light. I think it remains a little, I'm not sure. It was probably out there. I don't know why, but it was very interesting to see that it started this whole cascade of looking at head of starches, if you will, and whether or not they really were as beneficial as they've been reported. What else did you find?
So it was interesting to look at, a lot of even looking at before we started calling into question the benefits of using these, especially in patients that are extremely shocky, or questions about increased mortality after using them, is that a lot of what we were considering benefits of using them, we had extrapolated from human studies. And so we were kind of, the whole use of synthetic colloids, a lot of it has been empirically kind of extrapolating through the human side of things. So now that we've called into question with some recent meta-analysis and on the human side of things, and a lot of world organizations calling for the stopping of using of the synthetic colloids, we're kind of looking at that as well and saying, well, that's another extrapolation for the human side, or for our patients, the dogs and cats. So everything has to be very judicious as far as our use, and we just don't have the studies out there right now that can tell us exactly how beneficial they are. But of course, as we just brought up from the previous paper, there are some questions about using alternatives for colloids, the albumins. There's some reports in some studies that's causing anaphylaxis and other reactions in our dogs and cats. So what else do we really have to use at this point? That's kind of speeding through the article, but what I gleaned is that we can still use them, but we have to be very careful and judicious about when we do use them.
I think that paper made some comments about when it might be really okay or justifiable to use head starch, a couple of situations, and when they said the judicious use of it might be considered in these situations. Did you get that impression?
Correct. Indications. So the main indications for the use of HES in veterinary medicine include perioperative fluid therapy, absolute or relative hypovolemia, non-responsive to crystalloids, hypoalbuminemia, and decreased colloid onconic pressure. In addition, HES is used during hemodialysis as a priming solution and for preventative preloading in spinal anesthesia.
You know, the dialysis thing, I went, oh, great. And these patients already have kidney problems.
Exactly.
Thing, I wonder if anybody's done a study about priming with other fluids versus priming with HES in patients that, I wonder if the hemodialysis people are looking at that. You know, what are they doing in the human world when, and I think that would be an interesting thing to look at. I just didn't have time. But what are they doing in renal replacement therapy in people when the main priming solution has been these starches?
Right.
The thing in this paper I thought was interesting is that head starch is not actually FDA approved for use in dogs.
Right.
It's not really. We are using an off-label use in dogs when we actually use these starches, which I thought was also an interesting indication. Teresa, do you have any comments to add to the paper?
Let's see. I mean, whatever indications, like they mentioned with hypoalbuminemia and the decreased COP, what I found it interesting, I know we mentioned before, they talked a lot about the glycocalyx and just the damage to that, and how kind of with those two, maybe those aren't indications for giving it. It's because of the studies they found on damage to the protein glycocalyx, and giving these can either be detrimental or they can not be effective in the face of damage. I thought that was interesting. I don't know if that was mentioned before.
I'm really glad you brought that up because glycocalyx is a hot topic. Do you guys all understand what the glycocalyx is? You have a pretty good understanding of that? It's huge. Did you realize that it wasn't only until, what, 10 years ago, 12 years ago that we even could prove the glycocalyx was there in the endothelium? It goes back in human medicine, I would say 12, 15 years ago. They knew something was there because they did these sugar studies about sugar in the blood vessels, I'm paraphrasing this horribly, and how it got into the interstitium. And they knew there was an extra barrier there, but they couldn't prove it. And the reason they couldn't is when they were doing their histopath, they were using a stain that washed the glycocalyx away. And so they actually couldn't, with electron microscopy, see it. But then they started using a different kind of stain. All of a sudden, they realized that there's this extra layer of the glycocalyx in the endothelium that actually is the true colloid oncotic pressure differential about flux across the capillary endothelium. It's a fantastic read, and it's really super interesting, and I was happy that this paper went into as much detail because it also mentioned the revised Starling law of the capillary. I'm sure you guys probably in vet school learned about that and how it determines fluid flux across the capillary bed. That's all been redone, and COP is really not very important in the healthy blood vessel that has a healthy glycocalyx. We've now learned that a lot of conditions can cause destruction of the glycocalyx, particularly inflammatory and septic conditions with all the cytokines. And now there's some concern that when we volume overload these patients, hypervolemia, certain products that we use, that we're actually destroying the glycocalyx and contributing to capillary vascular leak syndrome, where you get all this interstitial edema. And that some of this is related to some of the things we do, some of this is related to some of the conditions, all of it's related to unhealthy glycocalyx. And that is huge and enters into all of our thoughts about fluid therapy at a much more nuanced level. Any other comment, Teresa?
I don't think so. It just seems like we need to do some research in veterinary medicine. again, it's all extrapolated from human medicine, so.
Yeah, it is, and we definitely need some. So what about you, Chris? You have other comments?
Um, I think that kind of rounds out my idea. I guess maybe I could get you to weigh in then on since the last couple of years, have you been more reluctant to use head of starch then and other synthetic colloids when you have patients come in?
Absolutely. And I will tell you what I'm doing right now after I talk to you about the paper I have to present.
Gotcha. Okay.
You ready to restart the timer?
Yep, I'll get it right now.
Okay. So in January of 2016, in the JVAC issue, there was an original study called Assessment of the Relationships Among Coagulopathy, wrong one, the one before. Retrospective cohort study on the incidence of acute kidney injury and death following hydroxyethyl starch administration. This article was written by Galena Hayes, and the anchor author is Carol Matthews. You all probably know Dr. Matthews. It is a really seminal article, I think, because it's the first one to be published in veterinary medicine. Galena Hayes is the originator of the Apple score. And if none of you know about the Apple score, I would encourage you to do some individual research on that. Really took the veterinary medicine research world by storm 2 or 3 years ago. She has an Apple canine and an Apple feline score. She also has an Apple fast. She has the big one, then she has the little one. So the PICO on this, the patient population, was dogs admitted to the ICU of a veterinary teaching hospital receiving 10% head of starch, and then it's the 250 0.5 substitution, molar substitution, compared with general ICU population while, this is cool, while controlling for severity of illness. The time frame for this retrospective was January 2007 to March 2010. They took a consecutive sample of dogs giving head starch, which was an N number of 180, compared to a random selected dogs in the ICU during the same time frame with an N number of 242. Intervention, there was none. The comparators were head of starch versus no head of starch. And what they were looking for was at least a double increase in creatinine, excuse me, or new onset oliguria or anuria persisting for greater than 2 hours. I guess I better not talk too long. Okay. So the results. Head of starch administration was associated with an increased risk of mortality in the unadjusted analysis. And in the adjusted analysis, after controlling for illness severity, admission type, and concurrent administration of blood products, head of starch remained an independent risk factor for the composite disease outcome of death or acute kidney injury. Now, what I found interesting is that they had a number needed to harm of 6, which means if you treated 6 patients, one of them would either die or have acute kidney injury related to their head of starch administration. Conclusion, of course, was randomized controlled trials are needed. So under the results section in table 2, they had some very significant p-values, and those p-values significance were related to the admission Apple score, the duration of ICU stay, the admission albumin, surgical admission, whether they were trauma or whether they were septic. So all of those factors were significantly associated in the head of starch group versus the non-head of starch group. The other thing that I thought was really interesting, that they said that the increase, the more head of starch you got, the greater chance of harm. Okay, so if they just got some boluses versus a CRI, versus how long they got the CRI, that seemed to correlate. with the development of the adverse outcomes. Now, one thing I thought was interesting is they didn't differentiate what crystalloid they got. You all are well aware that there's some controversy regarding sodium chloride, normal saline, and whether or not the hyperchloremic metabolic acidosis associated with saline can contribute to kidney injury. Okay? I would have loved to have known in these patients which one of them, if they got normal saline or if they got a balanced crystalloid solution, but that was not reported. Under limitations, they talked about it being observational, so they could only report association, not causation. It was retrospective, so the follow-up was limited to the point of patient discharge. They did not evaluate for the effect of head of starch on coagulation, and we all know that effects on coagulation is a big concern. And they only evaluated 10% head of starch with a 250/0.5 concentration. So they can't extrapolate, nobody can extrapolate that based on this information to the other types of concentrations of head of starch. For example, vet starch. I think vet starch is 130/0.4. So I think that this is a very important article, and I think it was really well done. One of the things, too, that I wanted to mention is that that there is an inherent possibility of bias in this paper because it used a multivariable approach. And with that type of approach, it's intrinsically limited by the number of variables. So if you didn't include a major confounder in that multivariable approach, then it could have an effect on the key variable, which was head of starch, and it may end up being biased. So, and they actually put that in their discussion, which I thought was really good. So we have to bear all of. Hello, Kaiser.
Oh, hello.
And then Braswell left the call.
Hold on, I'm trying here.
What'd you do to Braswell?
Kaiser, what'd you do with Braswell?
Hey, okay. Well, I've got Braswell. Whoops.
You stole her.
Whoops.
Way to go.
Yeah, this is what
Okay.
it is for.
I can see Braswell on my screen. I think I need to hang up and she needs to try to call back in with y'all.
Yeah, because she left our call to join you.
Whoops.
Okay, I'm back. Sorry. So, and my voice is better. Sorry about that coughing mess I had to go through. So, they eliminated one of the confounding factors by using the illness severity score, the Apple score. So you guys look that up. Have I reached my 10 minutes?
You're at 8 minutes right now.
Cool. So I'll use the last two to answer your question. I am not using head of starch in septic patients. I'm not using head of starch in patients that have evidence of ongoing renal issues. I am virtually not using constant rate infusions of head of starch, but I am using head of starch in a bolus therapy. For example, if I had a dog in surgery that became hypotensive, turned down the anesthesia or turned down the gas, crystalloid bolus still wasn't working, I would give that dog a bolus of head of starch. Okay, one. If I have a patient come in that's in hypovolemic shock, I will use head of starch to help that patient. If I have a traumatic brain injury come in, I will use head of starch and hypertonic saline for low volume fluid resuscitation. Those are about the only times that I will readily use the product. What am I doing for hypoalbuminemic patients? I'm giving them plasma. Okay, that's what I'm doing, like Luna, for example. So I gave her a couple of units of plasma and bumped her albumin up 0.3 or something, but she wasn't that low. So I'm using natural colloids in preference over the synthetic colloids at this point because I just don't know. Now, there have been a couple of situations where we've had severely hypoalbuminemic patients and money was an issue. So what I have done in those patients is I've sat down with the owners and I've explained to them the controversy in using head of starch for low albumin versus using natural colloids like fresh frozen plasma. And I've explained to them the difference in cost, and I've explained to them the risk. We have to do something about your dog's albumin. This is what the controversy is. This is what we know and what we don't know. And if we're going to do anything because we're financially constrained, we have to use this, or you need to make a choice to use the other. And I explain everything to the owners, and I let them make that choice.
Mhm.
I don't make that choice for them, especially if it's going to be a CRI and a septic patient, severely traumatized patient. I lay it all out there, and I let them make the choice, and I document it in the record. That answer it? Okay.
Yes, thank you.
Ken, you're welcome. Ken,